So hey guys, my name is Mayur Kaklotar, and today we will talk about very confusing and very important topic, which is a short topic, uh, Conus Medullaris versus Cauda Equina syndrome. So first of all, we talk about spinal cord. Now you have to visually think about it. So in an adult, the spinal cord will end at lower end of L1 to L2. Mostly it is a L1. And then here is in the last part, which is a cone like, that is called Conus Medullaris of spinal cord, and from there we have a nerve root coming out, because below L1 we have to supply lower limb and perineum and etc. Okay, so now roots is coming like this and going this. These all are now coming from particular nerve roots, okay, which is mostly lumbar, then sacral, then coccyx. Okay, so when the end of the spinal cord, which is conus medullaris part, when this is get trapped, or something lesion happen to it, or something external lesion which is cause compression on these, which will cause conus medullaris syndrome. Okay, and it will present as upper motor neuron lesion. So here is a spinal cord itself is getting into trap, so it is a upper motor neuron like lesion, which is a symmetrical bilaterally. Okay, and when these nerve roots are mostly get trapped when there is a intervertebral disc get prolapse, when nerve root or the below which passing nerve which get trapped, and it is look and there, and this will give you Cauda Equina syndrome. So here is a nerve root are getting trapped, so we will think about like whenever the nerve roots are getting trapped, peripheral neuropathy, or that is a lower motor neuron like lesion, and that is unilateral and asymmetrical. So mostly when the conus part is, now we will talk about conus medullaris. First of all, let's say what is upper motor neuron versus lower motor neuron. So we will say like this is our brain and the spinal cord are coming out like this. So and the nerve roots are going like this. Okay, when the defect this brain our cerebral cortex act as a upper motor neuron, and these nerves which coming out from spinal cord, which is act as a lower motor neuron, and we have this nerve will get act on the muscle, and act are done at particular time. And okay, so always remember like this, our brain is controlling everything below it. So upper motor neuron will control lower motor neuron, and lower motor neuron it's will get a command and do a movement. Okay, and first thing we remember, like upper motor neuron always controls lower motor neuron, and second thing we remember, lower motor neuron are always in hurry to act, and this means lower motor neuron get controlled by upper motor neuron, so that's excessive or that, let's say, abnormal movement doesn't occur. So when the upper motor neuron palsies occur, like when upper motor neuron lesion happens, there is no one to give command or control on lower motor neuron, and lower motor neuron get works its own fashion without any relaxation, which will give you spastic paralysis. So upper motor neuron lesion will cause spastic paralysis, and when the lower motor neuron damage, there is no one below to upper motor neuron to get or say collect order, so muscle will stay in relaxed position, which will cause flaccid paralysis. So lower motor neuron lesion always cause flaccid paralysis, and sometimes atrophy of muscles occurs. Okay, this is what we can say about what is upper motor neuron palsy and what is lower motor neuron palsy. Okay, now we move back on our topic, which is Conus Medullaris syndrome versus Cauda Equina syndrome. So Conus Medullaris syndrome, it is a lower part of the or say a ending of the spinal cord, which is Conus Medullaris, and which involved sacral nerve roots and coccyx nerve roots. And for the sacral we have a S2, S3 and S4. So we have a S1, S2, S3 to है sympathetic nervous system as well as parasympathetic nervous system. Sympathetic nervous system and parasympathetic nervous system. Sympathetic nervous system will act on detrusor muscles which contract and urination happen. And PNS symptoms parasympathetic nervous system, we have a pudendal nerve, okay, will act on or innervate external urethral sphincter, will cause urination as well as external anal sphincter will cause defecation. Okay, so when the S2, S3 and S4 dermatome get trapped or get damaged by something or some external lesion, there is always loss of the bowel and bladder function. So in Cauda Equina syndrome we have a earlier involvement of bowel and bladder. Okay, this is one point which is very crucial to remember, because this is the one which will differentiate from Conus Medullaris from Cauda Equina syndrome, because in the clinical variant they are always saying like this, like first anesthesia is occur like saddle anesthesia or perianal anesthesia, which I will talk about, which happen into Conus Medullaris and Cauda Equina syndrome. So they always giving you the sensory loss history, and then give the there is a early urinary incontinence or late urinary incontinence. So when they're saying in clinical variant like early urinary incontinence, so we have to think about Conus Medullaris syndrome. Conus Medullaris syndrome, or if they're saying like patient have a saddle anesthesia, which is like generalized anesthesia over the buttocks area, or that is going below into a thigh. So that's called saddle anesthesia. And plus they give you history like there is a late involvement of the bowel and bladder, like urinary incontinence or defecation incontinence. So we have to talk about Cauda Equina syndrome. Okay, and here is a S1, and then one more thing we have to remember, like S1 is for ankle reflex, and here in Conus Medullaris syndrome it get affected. Okay, and plus one thing, this is one second point, and third point, which is like here S1, S2, S3, S4, all sacral nerve roots get affected. So for S1 we say there is effect on the ankle reflex, and S2, S3 there is loss of the urinary incontinence, like patient will have a urinary incontinence and defecation incontinence, and for this dermatome it will cause perianal anesthesia. Okay, this third one point is, so for the Conus Medullaris syndrome we have to remember first of all like first we remember like there is upper motor neuron palsy. Then we have the upper motor neuron palsy, which is a bilateral symmetrical. Second is involvement of the S2, S3, S4, or which will cause bowel and bladder earlier involvement. And then we have S1, which is ankle reflex, for that is get affected also. And we third point we will remember, this is there is a perianal anesthesia. Okay. And Cauda Equina syndrome we will remember like lower motor neuron palsy, which is unilateral and asymmetrical. And here we will talk about why in Cauda Equina syndrome there is saddle anesthesia first, and second effect of ankle plus knee reflex, and third we have ankle reflex, saddle anesthesia, we have ankle and knee reflex, and bowel and bladder involvement, which is early or late. Okay, so there is affected and we have saddle anesthesia. Why? So now I am discussing 3 points as a contrast to conus medullaris. In the conus medullaris we have a perianal anesthesia, whereas here in Cauda Equina we have a saddle anesthesia because of there is involvement of the involvement of the lumbar plus sacral plus coccyx nerve roots. Okay. And in the second point is in the conus medullaris we have a loss of the ankle reflex, where here is we have a loss of the knee as well as ankle reflex because of the same concept. Because for the ankle reflex we have a S1 and for the knee reflex we have a L4. These both are get affected in Cauda Equina syndrome. And here is a bowel and bladder are late involvement. Why? Because here is a first of all we involve a lumbar, then we have a sacral, then we have a coccyx. So S1, S2, S3 and S4, S2, S3, S4, which is supply to bowel and bladder, like for the defecation we have bowel and bladder for urine, external sphincter. So here is a lower limb first involved, so here is a late finding of the bowel and bladder. So to sum up all the things, I make a new slide and I give you a point for which will we have to remember or not. We have a conus medullaris and Cauda Equina syndrome. First we have a upper motor neuron palsy, here is a lower motor neuron palsy. Second, here is a bilateral, here is a unilateral. Third is a spinal cord lower part get trapped. Here is a like we remember like these nerve roots or nerve get trapped because of intervertebrate disc prolapse. Okay. Fourth point we have, here is a perianal anesthesia, saddle anesthesia. Fifth one is a bowel and bladder early involvement, here is a late involvement. Sixth point we have like here is a ankle reflex get affected, knee reflex spade, here is a both are get affected. So you have to solve the clinical variant, it will come under the neurological, it will come in the topic of the neurology as well as orthopedic, or it will. So these two topic like differentiation mostly is asked, like you can get idea about, like they are talking about conus medullaris or Cauda Equina syndrome. You have to choose from out of these two whenever there is a clinical variant is there. So mostly they are used in clinical variant, these two things. First of all, it is they are taking bowel and bladder, which is early in Conus Medullaris and late in Cauda Equina. Then they are taking ankle or knee reflex, which is knee reflex is spared in Conus Medullaris, and both are get trapped in Cauda Equina. And second is they are taking anesthesia like perianal anesthesia in Conus Medullaris and bladder and saddle anesthesia, which is Cauda Equina. Okay, so thank you. 我谢谢。